updates in cardiovascular medicine.
We're looking at the August 2025 ACHA Joint Committee Guidelines for Adult Hypertension. And this is a huge moment in medical practice.
Right. When the American College of Cardiology and the American Heart Association speak, doctors definitely listen.
They do. We've pulled together the official reports, some crucial health advisories. There's one from the NYC Department of Health and expert commentary to really distill what these new rules mean for patient care.
And our goal is to unpack two massive and I think interconnected shifts. First, a huge structural change in how risk is even calculated. We're talking about the official removal of race from clinical algorithms.
And second, a very practical set of aggressive new treatment thresholds. New strategies designed to reduce your risk of major things like heart disease, stroke, and chronic kidney disease.
This deep dive is so essential because these guidelines, they don't just affect what your doctor might prescribe, they fundamentally change how your risk profile is assessed.
We're moving toward a truly personalized, risk-based medicine, but it's one that acknowledges societal factors that were often hidden by, simple biological assumptions.
Okay, let's unpack that shift in philosophy then. Let's start with what feels like a seismic change. The removal of race as a factor for picking that initial blood pressure medication.
Right.
For decades, many guidelines differentiated treatment based on a patient's reported race.
Right.
What was the thinking behind that old, now abandoned practice?
Well, the old practice, it really stemmed from these large population studies that observed, they saw different responses to medication. Specifically, the data suggested that Black patients, on average, seemed to respond better to thiazide diuretics or calcium channel blockers, CCBs, as a first-line therapy.
As opposed to ACE inhibitors or ARBs.
Exactly. So treatment became stratified by race based on that, perceived population-level difference in how well the drugs worked.
That feels incredibly problematic now, but I can see the historical logic if you're just looking at bulk data.
Sure.
The sources we reviewed, though, are emphatic that this practice is over. Why was it considered so harmful that it had to be explicitly abandoned?
The consensus now is that using race this way was based on what the reports call, and this is a quote, erroneous harmful practices of race-based differential biology.
That is a very strong phrase.
It's intentional because race is a social construct, right? It's not a reliable genetic marker. So using it as a proxy for genetics is just imprecise, and more importantly, it was actively detrimental.
How so? In what way?
Well, because it often steered physicians away from certain drugs that might have been crucial for other conditions. The most cited example is chronic kidney disease, or CKD.
Oh, okay.
For many patients with CKD, ACE inhibitors, or ARBs, are vital. They provide necessary organ protection, they reduce protein in the urine, they slow down the disease. So if the guidelines prioritized a CCB or a diuretic just because of a patient's race, it could lead to the undertreatment, or at least delayed treatment, of that critical kidney condition. It was reinforcing inequities instead of solving them.
So the goal now is precision. If race is out as a predictive factor, what is the new engine driving this risk assessment? This is where it gets really interesting.
It is. The new guidelines mandate the use of the AHA's PREVENT calculator.
PREVENT, okay.
Right. It stands for Predicting Risk of CVD Events. And this tool, it generates a 10-year and even a 30-year risk assessment for cardiovascular disease, so stroke, heart failure, heart attack. And crucially, it does not use race.
So what inputs does it use then?
It relies purely on measurable clinical and lifestyle factors. Things like sex, your current blood pressure, cholesterol profile, BMI, your eGFR for kidney function, and of course comorbidities like type 2 diabetes or your smoking status. It just forces a complete clinical picture.
But there's this amazing, almost counterintuitive detail that replaces those simple racial categories. The direct acknowledgement of socioeconomic risk, and it does it through geography. The sources all highlight the Social Deprivation Index, or SDI.
Yes.
And this is where your zip code comes into the picture.
That's the innovation. It's really aimed at genuine health equity. The SDI can be factored into that risk assessment, and it gives a quantified measure of socioeconomic disadvantage based on where you live.
So what are we talking about here?
We are talking about proxies for factors that truly drive health outcomes. Things like low income, lower education levels, high unemployment, housing instability, poor access to care.
Wait, so my zip code is now a more relevant health data point than a broad, imprecise biological category?
Yeah.
How does a doctor practically use that without, falling back on old stereotypes about poverty or location?
That's a great question. It's used not to stereotype, but to add a crucial layer of context to that PREVENT score.
Yeah.
So if two patients have identical physical stats, Same BP, same cholesterol, but one lives in a zip code with a high STI.
The doctor is nudged to recognize that they face structural barriers.
Exactly. Structural barriers that make achieving health goals significantly harder. Things like chronic stress or food insecurity. Those are often what drive disparities more than any assumed genetics. It ensures the physician is looking at the whole patient environment. It's powerful.
So the key takeaway here for you, the listener, is that your treatment is now driven by a truly individualized, measured risk score, that prevents score, and an acknowledgement that where you live, that structural disadvantage plays a real measurable role in your health.
Exactly. We're moving away from rigid prescribing based on identity and toward therapy based on demonstrable risk factors and environmental context.
Okay, let's transition from philosophy to the concrete numbers.
Yeah.
How does this new risk-based approach change the actual blood pressure classifications and, more importantly, the treatment goal?
Okay, so we need to nail down the updated classification first. It really reinforces the lower end of the spectrum. So normal BP is still less than 120 systolic and less than 80 diastolic. Elevated BP is that tricky range. 120 to 129 systolic, but still under 80 diastolic.
And then we get into actual hypertension.
Then you have stage 1 hypertension, which is 130 to 139 systolic, or 80 to 89 diastolic. And stage 2 is anything at or above 140 systolic or 90 diastolic.
So what's the goal? Where are we trying to get to?
This is absolutely critical, and it's the big practical shift. The overarching treatment goal for all adults starting treatment is uniformly less than 130 over 80.
Uniformly, even for people with diabetes or kidney disease.
Yes, for everyone. That uniform target, it signals urgency and a real belief in tighter control.
So what does moving from, say, 135 over 85 down to 125 over 75 actually buy me in terms of my long-term health?
A lot. The clinical trial data that fueled these guidelines, especially trials like SPRINT, showed very strongly that aggressive control, getting that systolic number below 130, dramatically reduces major cardiovascular events.
So you're buying real protection.
You're buying significant protection against stroke, heart failure, and heart attacks. I mean, this isn't just about feeling better. It's about reducing morbidity and mortality over the next decade.
Okay, so given these tight targets, how do the guidelines tell doctors to start treatment based on those stages and risk scores?
Well, for anyone who presents with stage 2 hypertension, so that's 140 over 90 or higher, the recommendation is aggressive. You start 2 first-line medications immediately, along with lifestyle changes.
2, right off the bat.
2, it reflects the high immediate risk that level presents.
And for stage 1, that middle range of 130 to 139, that's where the prevent risk score really directs the approach.
Precisely. If you're stage 1 but you have a high CVD score, so 10-year risk of 7.5% or higher, or if you already have diabetes or chronic kidney disease, you also start 1 medication immediately, plus lifestyle changes. The risk just outweighs waiting.
But what if you're stage 1 and low risk, maybe a 5% 10-year risk? Then you get a window of opportunity.
Yes, exactly. If you're stage 1, but you have a low CVD risk score, you get an initial 3 to 6 month trial focused only on lifestyle modifications.
So a chance to fix it without pills.
A crucial window for the patient to take ownership. Make real changes, day-ace diet, weight loss, exercise. Medications only started if, after that period, their blood pressure is still at or above 130 over 80. Lifestyle is the gatekeeper for that low-risk group.
And what about those core lifestyle recommendations? Beyond diet and exercise, are there any specific non-drug therapies that the guidelines are pushing?
They're strongly recommended for everyone with elevated BP and hypertension. And the key additions are really around stress reduction.
Ah, interesting.
Yeah, the guidelines specifically mention things like transcendental meditation, yoga, and guided breathing exercises. They're recognizing that clear physiological link between chronic stress and high blood pressure.
And what about salt?
They also encourage using potassium-based salt substitutes. But, and this is a critical safety warning, if you have pre-existing kidney disease or any risk for high potassium, you must avoid those substitutes.
Let's focus on medication strategy for a second. You mentioned starting 2 medications for stage 2. Why the strong preference for what they call a single pill combination, or SPC?
This is a huge logistical focus, and it's all about adherence.
Making it easier for people to actually take their meds.
Exactly. A single pill combination means you take 1 physical tablet that has 2 different drugs in it, maybe an ACE inhibitor and a calcium channel blocker. The evidence is just overwhelming. If a doctor prescribes 3 different pills, morning, noon, night, that pill burden quickly leads to people not taking them.
It makes perfect sense.
By combining 2 agents into 1 pill, you dramatically improve the chances the patient will take the full therapy. You get faster and more sustained control.
Okay, switching gears to diagnostics. There's an important update about resistant hypertension when your BP stays high no matter what.
Right. This is where we see the search for underlying causes getting broader. And what's fascinating is the expanded screening for something called primary aldosteronism.
That's a hormone-driven cause, right?
It is. And previously, screening was often triggered by low potassium. But now, the 2025 guidelines say to screen all adults with resistant hypertension for it, even if their potassium levels are normal. The goal is to catch way more cases, because if you treat the aldosteronism, the blood pressure often just falls into line.
This brings us to a detail that affects every single listener and every single healthcare provider: measurement accuracy.
Oh, this is maybe the most actionable part of the whole guideline for you.
Because all these aggressive targets are meaningless if the reading is wrong.
Totally. Inaccurate readings can wrongly delay treatment or, on the other hand, wrongly trigger it. For example, just having a full bladder can add a full 10 millimeter Hg to your systolic reading.
10 millimeters. Just from a full bladder, that could literally flip someone from low risk to start medication now.
It absolutely could. An unsupported back or feet. That adds 6 millimeter Hg. If the cuff is over your clothing, which still happens all the time, it can add anywhere from 5 to 50 millimeter Hg.
50. Wow.
And just talking or actively listening during the measurement can add another 10 millimeter Hg. These are huge variances. It just confirms that best practice is non-negotiable.
Which is?
Sit quietly for 5 minutes, back supported, feet on the floor. Take 2 measurements 1 minute apart, and you can even discard the first one. Accurate measurement is the foundation of all of this.
Let's quickly hit a few advanced topics for specific populations. Starting with pregnant individuals, we saw a really key safety note here.
Yes. For pregnant individuals with chronic hypertension, treatment is now firmly recommended at 140/90 or higher. The preferred agents are still labetalol or extended-release nifedipine.
And the safety note.
The critical thing for our listener is this. ACE inhibitors, ARBs, and direct renin inhibitors are absolutely, completely contraindicated in pregnancy. They carry a severe risk of fetal harm. And separately, low-dose aspirin is recommended after 12 weeks to reduce the risk of preeclampsia.
What about the brain? Is there a BP target for protecting our cognitive health?
Yes, there is. The guidelines specifically address cognitive outcomes. To reduce the risk of mild cognitive impairment and dementia, the recommendation is to target a systolic blood pressure of less than 130 millimole Hg.
So that tight universal target isn't just for the heart and kidneys, but for the brain, too.
Right. It seems to reduce that microvascular damage over time.
And we also saw new terminology around really severe cases. What happened to hypertensive urgency?
That term has been replaced by the more straightforward severe hypertension. It's defined as a BP over 180/120 without new or worsening organ damage.
And what's the practical advice there?
The guidelines caution against routine use of IV blood pressure meds in asymptomatic hospitalized patients. They note that the risk of harm from dropping the BP too fast often outweighs the benefit in those situations.
And finally, a brief mention of a procedure. Renal denervation, or RDN, is back on the table.
It is. RDN is a procedural option for very carefully selected patients with resistant hypertension. It involves a minimally invasive ablation of nerves near the renal arteries.
Why was it out and why is it back?
It was initially shelved because of some mixed trial results, but newer trials with refined techniques and, importantly, better patient selection have shown it works. It's back, but it's not a first-line treatment. It requires a whole team evaluation and shared decision-making with the patient.
And one last new pharmacologic mention for people with comorbidities.
Yes, a quick one. They mentioned the potential to add GLP-1 receptor agonists as an adjunct therapy for patients who have hypertension and are also overweight or obese, so a BMI over 27. These are the weight loss drugs that also have cardiovascular benefits, so they're seen as a valuable addition in complex patients.
Okay. We've established new thresholds, a new equity-focused risk calculator, and these aggressive treatment goals. But for you, the learner, context is everything. How do these aggressive U.S. guidelines stack up against what the rest of the world is doing?
That is such an important question, and the answer is they don't really stack up. There's a very real transatlantic tension here. The U.S. guidelines are notably more aggressive than those from the European Society of Cardiology, the ESC, and the European Society of Hypertension, the ESH.
Where do they diverge the most?
Primarily on the definition of hypertension itself. The AHACC maintains that aggressive stance of stage 1 hypertension starting at 130 systolic.
And in Europe?
In stark contrast, both the ESC and ESH use a higher threshold systolic at or above 140 and diastolic at or above 90 as their formal diagnostic threshold for hypertension.
So if my systolic BP is 135, I'm officially labeled a stage 1 hypertensive in Dallas. But if I move to Berlin, I'm just considered high normal and don't need immediate medication. That's a massive philosophical difference.
It is, and it has huge clinical implications. The U.S. standard diagnoses millions more people as needing intervention. And the treatment targets differ too. The ACC uses that uniform, aggressive target of less than 130/80 for pretty much everyone.
And the European guidelines use a more stratified approach. What does that look like?
It means they tailor the target based on age and frailty. For younger, fit adults, they might aim for a really tight range, maybe 120 to 129 systolic. But for frail individuals, or those aged 80 or older, the European guidelines allow a much higher systolic target, sometimes up to 140 or 150.
Why?
They recognize that dropping pressure too quickly or too low in the elderly can cause harm, like fainting or even stroke.
So why is the U.S. so much more aggressive with its definitions and targets?
Well, the commentary we read suggests the U.S.'s aggressiveness reflects more than just clinical trial data. It also aligns with some regional U.S. healthcare realities, specifically the structural and financial system.
You mean payment incentives?
Essentially, yes. In the U.S., primary care practices are often evaluated and reimbursed based on quality measures, like HEDIS scores.
And what does HEDIS have to do with my blood pressure target?
Well, HEDIS measures reward clinics that keep their whole population's blood pressure low. To consistently meet those population-wide benchmarks and, maximize those positive payment incentives, the simplest strategy is to just push the individual treatment thresholds lower across the board. The sources suggest the aggressive 20-30-80 target helps U.S. practices hit those ED scores more reliably.
So it links the clinical recommendation directly to system-level financial priorities.
It seems to.
Okay, so let's offer a final summary. What are the two most important points for our listener to take away from this deep dive?
First and foremost, that monumental shift toward individualized, equitable risk assessment. Race is gone. It's replaced by the rigorous PREVENT score, which, for the first time, integrates structural factors like your zip code's Social Deprivation Index score. That's a game changer.
And second, the universal and demanding treatment target. The goal is now uniformly less than 130/80 for almost all adults, demanding earlier and often dual medication intervention for those at high risk or in stage 2.
And, a final thought on the broader public health challenge. The guidelines recommend not just medical interventions, but policy-level changes, like mandated sodium reduction in processed foods and multidisciplinary team-based care, because hypertension is fundamentally a public health challenge. It's driven by environment, stress, and access, not just individual biology.
So since the ACC guidelines now officially emphasize that structural factors like food insecurity and chronic stress often matter more than the precise choice of medication, here is something for you to consider. How does understanding your own social deprivation index score, that quantifiable risk tied to your zip code, change the conversation you might have with your doctor about managing your overall health and maybe demanding support that goes beyond just a prescription? We'll leave you to think on that.